The idea of choosing peripheral, I think it's more than one reason. There are the logistics of this. It's easier and safer on the donor for sure, and there is a big emphasis of keeping transplants, improving outcomes for patients, but also keeping them very safe and easier for donors, right? It's like that's one of the mandates, I guess, we have to these donors that are doing this for our patients. And number two is that we have already explored this platform in the bone marrow setting. So we did this a few years back on the 15 MMUD trial. It was a smaller study conducted at 11 centers. The reason why we started with bone marrow was that historically, the rates of chronic GVHD with a bone marrow graft were lower, right? But we have to remember that this is usually in the setting of a traditional GVHD prophylaxis. And I think the logical question was, peripheral blood is really the graft of choice for many, many reasons, logistic being one of the main drivers. And can we deliver the same platform? Can we use the same platform to deliver safe and effective transplants using peripheral blood? And that was one of the questions that the trial answered. And the question is, yes, we didn't find higher rates of graft-versus-host disease, which is one of the main issues. And there are many other advantages to using peripheral blood. You get a higher cell yield, collection can be more uniform across centers. Some people would argue even risk of relapse is minimized when you use a peripheral blood graft. So I think there are many reasons why you will preferentially go with a peripheral blood. We tested the theory in a kind of like safer, if you may, first level area when looking at bone marrow. And we have found that the outcomes in terms of GVHD are very comparable when we use a bone marrow graft, when we use a peripheral blood graft, which is logistically much easier, much safer for the donor and easier for the donor center too.